Thank you, everyone. It's a great privilege to talk to everyone, Spanish-speaking world. I apologize that my Spanish is not up to using your wonderful language. And it's a particular privilege to speak to everyone who's either living with, has lived with, or has some contact with ALS, or as you know, also referred to motor neuron disease, particularly in England. I keep to ALS and I'm using the terms interchangeably, so without particular significance for one or the other. Now, I think everyone out there listening is even more aware than I am of the nature of this condition and of how difficult it is to face the diagnosis, to come to terms with it, to cope with it, to manage it, and all its implications. It can be tragic. It's usually difficult, always difficult. As physicians, as neurologists, we're all too conscious of the limitations that we have in offering you the help and support that you really need and deserve. Of course, we have made some advances, and that in terms of care, but that depends very much on where you are, your circumstances, and so on. It's very unequal throughout the world and throughout my own country. We do know that providing multidisciplinary care, that's input through other health professionals, can make a difference, but it's still a great challenge to people living with this condition. And so when I'm in the clinic and I'm meeting somebody who almost certainly has motor neuron disease and assessing the diagnosis, I know what they're thinking, and they will say it aloud. What's going to happen to me when? How am I going to cope? And what can you do about it? And we have to be honest and say we have very limited tools at our disposal. We have only one drug, at least in Europe and in the States, which is licensed because it has been shown to improve the survival, the overall progression of the disease. There is in the States, at least, I'm not sure about in your countries, edaravone, which has only been shown to have a small effect on function, but not on survival. And this is after, or at least in my case, over 40 years of research. So what have we been doing all this time? And why haven't we done better? So I'm going to touch on these issues and try and explain the challenge that we faced and also the hope that we now have in view of the very rapid advances that have been made in research, particularly over the last 10 years, but really starting with our understanding of the genetics of ALS. Not that everybody, as you know, has a genetic or hereditary form. It's not that common, but it has given us vitally important clues as to what may be going on as the switch, if you like, the trigger for this disorder, this disease. But what I'm going to focus on really is in the context of that, of our advances in understanding some of the causes, the challenge to trying to find new treatments and explain why it has been difficult and where we are now. And I'm going to give you some indication of a study which will be published very soon, within the next month, on a compound or a molecule known as interleukin-2, and try and share a little bit of what that means. So I'll go on. So I work at Brighton and Sussex Medical School, University of Sussex and King's College London. And I know that you've already heard from my great friend and ex-PhD student, Professor Amar Al-Chalabi, who's a wonderful example of a dedicated researcher. So I show you somebody you'll recognize, Stephen Hawking. And of course, you'll say, well, he was unique. And that's true in every way, intellectually, but in terms of MND. But it shows that not every person with MND is going to, if you like, run out of time within 2 or 3 years. there's a secret there in Stephen Hawking's life, which we don't understand. Why is it that his disease progressed much more slowly? And there are many possible reasons, and I could speculate, but there are many, many questions. And he raised many of these himself, and he was a great supporter of research on MND. So that although we have made some progress, we have very many questions about the biology of the disease, about the variations from person to person. So I'm going to introduce a concept here, which I'm sure you may be familiar with, which is heterogeneity. So that's, if you like, a technical term. What it means is with ALS, we're probably not dealing with a single disease. Now, there are other diseases, which are, for example, hereditary diseases like Huntington's disease, where the gene defect is essentially the same in every person. That's a simplification, but it's essentially the same. It's the same gene. If you have that mutation, you're almost 100% likely to get the disease. For ALS, it's much more complicated. We already have something like 40 genes implicated, and that's only in 10 to 20% of the people we see in the clinic. The other 80%, we can't find any gene defect. And this is what we mean. This is a disease, this is a syndrome, and this has been really a revolution since I started in the field 40 years ago. In our concept, we thought it was one condition we were aiming for to target with treatment. We now know that it's much more complicated. So that makes life more difficult for all of us, but we have to rise to the challenge. Now, I just start with Riluzole, which some of you will be taking. Now you'll say, well, I can't, it's not doing anything for me. I can't detect any change, and you're absolutely right. I got involved in this, and the person in the middle here with the spectacles on is my long-term friend and colleague and collaborator, Gilbert Ben-Simon in Paris. And he designed the first study on Riluzole published in 1994. And that showed that it does slow down the progression. It improves the significance at the end of a trial of 18 months. In a randomized trial where people are allocated blindly, they don't know, the doctors don't know, to Riluzole or the dummy, the placebo. But the effect is a small one, so that this is just another analysis. The two curves show the survival curve. So you can imagine on the left-hand side at the top where it says 1, that's when you put all the patients, you pretend that they all start together in the trial. It's 100% there, 1 is 100%, and you follow them over 18 months. And sadly, some will die. And the yellow figures are the yellow lines are the placebo, and that's going down faster. And the white line is the Riluzole, and that's going down slower. And the difference at the end, in terms of gain in survival, is about 3 months. Now, people always say, or at least other neurologists say, I don't, well, it's just giving you a couple of months. But that's only at the end of 18 months. And if you look over the lifetime of people with MND who may go on for 3, 5, 10, or if you're Stephen Hawking, maybe even 50 years or whatever, then the gain in survival may be as much as 19 months in some studies that have followed patients up. So I am the last to praise Riluzole as the answer. We know it's not the answer, but it does have an effect. So this begs the question. So when I'm in the clinic and somebody is sitting in front of me and I'm saying, look, I'm sorry, this is MND, let's talk about it, ask me questions. And they say, should they take Riluzole? I say, well, the choice is yours, but it does have some effect. And what we can't say is whether it's going to have a bigger effect in you as an individual or in that other individual or none at all, because it's a statistical effect. And this is where this concept of heterogeneity, this is not one disease, comes in. So we can't say that it's going to be effective in one and not effective in the other. All we can do is treat everybody. So we just don't know about this personalized medicine. All right. So what about other treatment? Well, you may have read about treatments aimed just at certain gene mutations. And this one is for what's called SOD1 ALS, which is ALS due to a mutation of the superoxide dismutase type, superoxide dismutase 1 gene. And this was the first gene identified as being abnormal, as being mutated in ALS back in 1993. And it's taken this time to get to a treatment known as an antisense oligonucleotide, tofersen, which interferes with the production of the mutant SOD1. And it has been shown that it slows the disease, although it's a difficult story because the trial didn't show a very convincing effect. And they relied on what we call biomarkers, that is, molecular markers of change, to make their argument for this drug compound to be approved. And it is now being used in Europe and North America, and I expect it's being used in South America and so on. But it's not the end of the story, because it's clearly having an effect, but we don't yet know enough about it. It's relatively new, and to say how long its effect will be and how sustained. So this is very exciting, but still we have a huge amount to learn about this approach. And of course, these antisense oligonucleotides, which interfere with the production of an abnormal or mutant protein, are being applied to other types of gene mutations, but they're phenomenally expensive. And they're only going to target a very small number of people. That is, perhaps 2 to 3% of all people with ALS have these mutations, or this particular mutation. If you can hear my dogs barking in the background, I apologize, but I can't stop them. In terms of, so how do we go forward? What is our strategy for finding new treatments? Well, so I put a cell there. If we were to put cells in dishes and study them, and we do, obviously, can we pour drugs on them and see if we put ALS genes into these cells, as we can do? In fact, we can take cells from skin and turn them into nerve cells now. It's fantastic. And then we can put drugs on them and to see whether it makes them live longer. But that's completely isolated from the complexity of the human system. Similarly, for mice, what have mice told us about therapy? Not very much, with the exception perhaps of the SOD antisense oligonucleotide that was developed in cells in mice, and that's worked. But that's a minority of people. So where do we go? And this is a little quote from an English poet writing in the 18th century. Know then thyself, presume not man to scan. I've changed it to mice. The proper study of mankind is man. And this really leads me to the idea that what we really need is a better experimental medicine approach. That is, to use people with MND, use, I say, in the sense, of course, of ethically collaborate with, as all our trials do, but to exploit, if you like, the human experiment. Because that's the only true form of ALS. And I think we need the cells, we need the mice, but we need to be much more intelligent in working with people living with the disease to understand it. And that's what we've tried to do in the study I'm going to very briefly discuss for you. So here's a sort of schema of what the challenges are. So there's disease heterogeneity. We're not dealing with one condition, we're dealing with a syndrome. So one drug like Riluzole may have an effect on some people, not on others. The targets that we're looking are very speculative, have often been driven by financial reasons or just speculation. And because we don't fundamentally understand the cause that might link all cases together. So we have to speculate. We don't often know whether the drug we're giving has actually hit the target we think it should hit, because we can't measure it in humans. And we talk of surrogate markers. What we mean by that is biomarkers are molecular markers, or could be imaging, MRI markers, whatever, that actually reflect the clinical change. We don't really have those. And what we've tried to do in the study that will be published soon in the Lancet, it's called MIROCALS. And that's where do we go on the compass from there? What we tried to do is fill in some of those. So disease heterogeneity, we tried to use a biomarker called neurofilament heavy chain in the spinal fluid. And all our patients in the study were asked to have up to 3 lumbar punctures, and bless them, they rose to the occasion because I think they understood that we had to do that because the spinal fluid is the closest to the brain and spinal cord. So we measured that. We used a drug, and I'll come to that, called, it's not really a drug, it's a compound that's present in all of us, helps regulate our immune system. It's called interleukin 2. And we knew that we could check its effect on the target because its target were cells called regulatory T cells or Tregs. So we could measure that. We've shown that. And finally, we're going to use this neurofilament marker again as a marker of response because we knew that it correlated with survival. So that was our philosophy anyway. And what we were looking at was a mechanism known as neuroinflammation. It's not a very good term because it's not infection. It's not really inflammation. It's a reaction of cells in the brain and spinal cord to damage. These are cells called glial cells, particularly cells called microglial cells. And they react, and we call it inflammation. And they are regulated by many factors, including these Tregs, which circulate in your blood. These are white blood cells, and they cross into the brain and spinal cord, and they talk to these microglial cells, and they damp down inflammation. That was our hypothesis, if you like, as stated here. And so the trial was called Modifying Immune Responses and Outcomes in ALS, and it's in press in the Lancet, and we hope it will be published in early May. And what I'm going to show, just very briefly, is just one bit of the results, because it's a complex study. You'll be able to read it in due course if you wish, because it'll be open access. But we showed that in a certain subgroup in which this spinal fluid neurofilament, PNFH, was rather low rather than very high, there was a difference in survival, the blue line, in favor of interleukin 2, which was, I can explain how we give that in a minute, versus placebo, the red, of almost 20%. So, and overall, the message was it's reduced the risk of dying at the end of, it was 21 months after 18 months of treatment, by about a half in these patients. So that's a significant improvement in the risk, if you like, or the chances of being alive and with us at the end of that period of treatment. Now, there's much more detail in the paper, and I haven't got time to go into that now. But there was also a change in favor of interleukin 2 with the functional measure called the ALS Functional Rating Scale, revised, which measures day-to-day function. It's not brilliant, but it's recognized as probably the best tool we have of charting the progression of the disease, apart from survival. And there was a modest effect on that in favor of slowing down the progression. And very importantly, interleukin 2, this is low dose, was very safe and very well tolerated. Now, how do you give it? Well, it was given by subcutaneous injection, small needle under the skin, well tolerated. And we say low dose because actually interleukin 2 is licensed at high dose, 10 times the dose almost, for treatment of cancer, in which case it has quite nasty side effects. But at this very low dose that we use it, it's very well tolerated. But what it does do is it bumps up these Tregs, these regulatory T cells, very powerfully. And we were able to show that damped down inflammation in the body, and we assume in the brain and spinal cord as well. Well, that was more difficult to show. We have more work to do on that. Right. So my conclusions really are, at the moment, only one drug, which is Riluzole, developed, were licensed with us in 1995, 96, has shown a survival benefit. And that's not through want of trying. Many, many trials. I counted 200 trials since 1978. And it's chastening to think how little we have achieved, despite all the efforts. So we need to get wiser about it. And I think this experimental medicine approach is going to help us a lot. Gene therapy is very promising. It's only going to be available really for small groups of patients with those particular gene mutations, SOD. There's one called fuzz. There are many others. But it's phenomenally expensive, and it's early days yet. ALS, I'm just trying to, there we are. Well, heterogeneity, I've talked about. Don't worry about type 2 errors. What that means is that if we do small trials and we do them too quickly, we may miss an effect. It took time for us to see both the Riluzole effect and the interleukin-2 effect. So always keep going with a trial, at least for 18 months in our view. I've already mentioned that IL-2 at low dose seems to prolong survival and reduce functional day-to-day loss in patients with, mainly in patients with less aggressive disease. That may simply be because it's more difficult to, yeah, sorry. Are we all right? Yes. And that building in this biomarker in the CSF, and there are others which you can use in the blood, which make it much easier, of course. I haven't dealt with that here. We've also done that. May be useful for, if you, by the term stratifying, we mean dividing patients according to these biological differences inherent in the disease, and differences between people, which we don't fully understand. And it certainly in this study, this CSF PNFH was extremely helpful in identifying a group that was responding, and sadly, another group with more aggressive disease, which didn't seem to respond. Now, that doesn't mean to say if we didn't give them a different dose, maybe a slightly higher dose, or study them for longer, or give the dose in a different way, we may have missed an effect. But this group deserve a lot of attention because they are they're the most difficult to treat. So we shouldn't abandon them. Of course not. We never will. But that means we have to think very carefully about how we deal with that. And the only other thing which was disappointing is that we didn't find changes in these biomarkers in the brain or spinal fluid. So the details of the mechanism by which IL-2 and interleukin-2 low dose is acting needs further work. And we do have lots of samples from our patients who have generously donated blood and spinal fluid for further research, which is ongoing. And I think I just need to move something around. So what's the conclusion? Is interleukin-2 ready for treatment? Our own view is our results are still preliminary. We would like to see a bigger trial to establish beyond any doubt that our results were true, and to explore other ways of dosing and delivering interleukin-2. It can't be swallowed because it's a small protein. It would be chewed up in our stomachs, if you like. So it has to be given either by subcutaneous injection. That's the obvious one. It works like that. But we could give it more frequently. For example, we only used a treatment 5 days every month of injections for the first 5 days of every month. It could be that we could spread that out, and that might be more effective. So there are different approaches to this which need to be explored. So we will recommend, and our conclusion in the paper is that we recommend further trials. But we believe that low-dose interleukin-2 has a real potential for a treatment as add-on to Riluzole. It's not the end of the story, in other words. And we will be obviously working with pharma to develop this. They have the right. We have a pharma company based in Paris that has a right to use this data to go to the regulatory bodies to see what's the next step, to see whether this could be used as a treatment for ALS generally.
Okay, so thank you so much for that, Professor Leigh. We've been planning on contacting you and talking to you for a while because all these interleukin studies have also been going for a while, right? We've been hearing a lot of news for quite a few years already, because as we know, research, especially in a disease, in such a complex disease like ALS, takes time, takes some time, and we need to find those treatments for our patients. But before that, we need to really understand this very complex and heterogeneous disease. So just to put the information in order, we have heard about iModels, MIROCALS. Is MIROCALS still a phase 2 trial that needs to go into phase 3? And what is the difference between the different studies that we've been hearing lately?
Yeah, it is confusing. I know. So we did a phase 2A study called IMODALS. And what the phase 2 studies are doing is looking particularly at safety and tolerability, and also trying to get some hint about whether there's effectiveness, whether it's efficacy, that is, whether it really works in changing the course of the disease. But they are generally not big enough to answer the question of efficacy, effectiveness, conclusively. But of course, there's a gray area. And in a way, MIROCALS, so IMODALS was only 36 patients with interleukin-2, given in the way I described subcutaneously. So that's very small. It was just about safety and about looking at some biomarkers and showing that we could upregulate these regulatory T cells with IL-2, and we showed that. MIROCALS, in which we recruited 220 patients and followed them all for up to 21 months after 18 months of treatment. We followed them up a bit longer for various technical reasons, but the treatment was 18 months. Some people would argue that that's big enough for a phase 3. So there is no absolute definition of what is a phase 2B, that is a bigger trial, but still looking at safety and biomarkers, for example, but admitting that it may not be big enough for the regulatory authorities like the Food and Drugs Administration or the European Medicines Agency to say, yes, this is a treatment. And the reason we didn't go straight to a phase 3 was that people normally proceed in this way because they want to get as much evidence of safety as they can. And secondly, because that was all we could afford to do. We were not a company. We're an independent clinical collaboration. And so we had to find the money. And the only money that we could find sufficient to do a complex trial like this was from the European Union through their H2020 program in collaboration with the Motor Neuron Disease Association of England, Wales, and Northern Ireland. Very generous and very important collaborators. And so we did this on a shoestring. And of course, if we could have had the money to do twice the size of a trial, that would have been phase 3. But that was the limit of our budget. So I think that, as you suggested, we do recommend that there should be a larger, not necessarily longer study, to really prove that there is a significant effect on survival and function.
And it looks like it would potentially it will work as a combination along with Riluzole. Is that
Absolutely.
correct?
Yes, and we designed it precisely for that because we clearly believe the evidence, not just because we were involved in that, and I have no financial interest in Riluzole, unfortunately, but from the science, um, it's clear that Riluzole does affect survival. And therefore, it's much better to do a trial where everybody is on the standard of therapy, which is certainly true for the UK and France, which is where we carried out the trial. And so that we can say that this is add-on to Riluzole. And therefore, whatever we're seeing is a gain over Riluzole, we have to assume because of the design of the trial. It doesn't mean to say that you couldn't use interleukin-2 without Riluzole. So if somebody didn't get on with Riluzole, it didn't agree with them, there'd be no reason why you shouldn't use interleukin-2, in our opinion. And clinicians will always, I think, do what common sense dictates for the care of their patients. So I wouldn't want to exclude any patient, even the more aggressive ones, or where we couldn't show a definite effect, because none of us, when you're looking at a person in the clinic, can tell which group they fall into. And even if you could measure all these biomarkers and put them in a particular category, it's a statistical effect, and that means you can't always get it right. It's an average. Therefore, the clinician has to have some humility in front of the patient and in front of the data and say, yeah, well, you may be in a worse group, but I don't know for sure, and I'll give you the benefit of the doubt. That would be my view as a clinician.
Clear. Okay, Professor Leigh, you've been working on ALS for how long?
I really got involved in it in the research in about 1986. So what, that's 40 years or something coming up to.
Hmm.
And yeah,
Yeah. Well, as you know, we talked to Dr. Al Talabi a couple of weeks ago. He used to be your student, like
he taught me
around
more than I taught him, I think.
about 30 years ago, I guess, or
Yeah,
so. And I was telling him we went to the annual symposium and the alliance meeting in Montreal this last
yes,
December, and we came back with sort of a pretty clear concept. We came back home with a pretty solid idea about the new stage that the ALS research field is going to right now. It's about to transition to right now.
yeah,
It looks like we were having a lot of clinical trials, which is exciting, with a lot of phase twos and phase threes. But now it seems like we need to step back a little bit and try to really understand the disease before continuing to attack the goal without really knowing what the game is about. This is a very complex disease again, and it looks like the ALS research field is going into into a stage where we really need to look for more biomarkers. We really need to look to see how many other mechanisms are involved here and what is going on inside the patient's body, and we need to do that before again starting to attack and starting to have more drugs, so we can get more effective treatments. That's the way the whole the landscape is looking right now. Would you agree with that?
I would hate to to argue against people doing trials. I think we have a new and a better approach, which is what we've tried to do in MIROCALS. We've been talking about this for many years now, building in these biomarkers as indicators of this heterogeneity to try to avoid lumping all the people together in one group and therefore missing an effect, which is perhaps only seen in a subgroup. And that's still a challenge. But so I agree with you that we are at a transition. I think there is such a rapid explosion in understanding basic mechanisms that we may see some key emerging, the golden key, which unlocks, if you like, a common mechanism which we can then target. So so what I hope that we will just use the information that we now have more intelligently, if you like, when we use whatever drug comes up. And I would hate to put us to tell people not to do a trial if there's a good rationale, even if it's not the certain. But if it's a reasonable rationale, it's always good to do a really well conducted trial and build into it these biomarkers so that you can see, and you need to do that up front, which I think we're the first to do. The Tofersen study did use biomarkers, but actually it was only after the effect, after their primary endpoint, the function was negative. They went back to the biomarkers to look at those and show that there was a change. What we have to do, because the regulatory agencies are very strict about this, is you have to predefine what you're going to do so that you're not then manipulating the results afterwards. It has to be predefined up front. And I think that is going to happen because we now have data from Tofersen, from our study and others. So I think we're just going to use methodology better. I think I wouldn't like to put a stop to any trial. I think we all need to pause and think very critically about what our hypothesis is. But we have a mixed economy. We have companies which have got something based on cells or mice, and they want to try it. And I would hate to, to discourage them doing that. As long as the trials are well designed and are not, trying to exploit what's happened. And we've seen this, as you well know. We've seen companies saying, "Oh, we've got data in 8 patients. This works. It's wonderful. Everybody should take it." But it costs $100,000 a year for each patient. That we must avoid. So I think responsible trials using biomarkers and trying to understand the biology of the disease, as you say. And every trial is an experiment in understanding the disease. That's what we really need, the philosophy. That's the experimental medicine approach. And I think that's coming, that is going to come in, that has come in.
Excellent. And but we did receive exciting news from your country recently. All these things we were talking about with Amar, with Professor Archalabi a couple of weeks ago about this new UK M&D, this M&D Research Institute, and all the different projects that money, those funds are bringing, right? Like Experts ALS, like the Longitude Prize, etc., etc. So that is exciting, and it looks like it might be the way to understand the disease better.
I think that the scale of research compared to even 10 years ago, certainly from when I started, there was almost nobody else doing research in ALS in the UK. I mean, there was a much better tradition in North America. And other parts of the world. But of course, it's changed beyond recognition. And I think the UK Research Institute is a fantastic initiative. And under the leadership of Amar and Chris McDermott, it's really flourishing. So I think it will change the pace of research and the pressure to keep the momentum going. I think also it's that sort of initiative is beginning to happen elsewhere. It's happening. It certainly happened in Holland, in other parts of Europe, Germany, and I'm sure it could happen across South America, across Latin America. I see no reason why not. I know there are challenges, but the other great benefit of that sort of approach of building structures, collaborative structures, is that it'll foster international collaborations. And we can all benefit from that because we need to understand the biology of the disease across different populations in people with different genetic backgrounds. It's really crucial. And that can give us really fundamental clues about what's going on in the disease. I've no doubt. And that's starting, but there's a huge amount more to do. But I think the basis for those collaborations is being laid now. And your association, I'm sure, is incredibly important in that sort of initiative.
You really anticipated my last question. Yes, because we've been around for a while in the ALS Association of Argentina. We've been part of the International Alliance for almost 12 years. And yes, we are really pushing for international collaboration in order to stop duplicating that much, and in order to be always in contact, we be always interlinked, so we can together, the different regions of the world, push to find those answers. And it really looks like this during these last years, the whole field has been pushing for that, has been moving towards that direction. We really need to stop duplicating and get all our data together in order to get, as you said, a larger and more and a larger variety within our pedigree, within our different ethnic groups, and to cover all that heterogeneity. And it looks like we're getting there. It looks like we are moving towards that direction as well. Would you agree?
Well, I hope so, because I agree with you. I think it's absolutely fundamental. And I think that also collaborating, not necessarily doing the same trial, but collaborating, having different centers for doing trials with similar methodologies so that we are not, comparing apples and pears or peaches and bananas and something, that we have a similar philosophy, not identical, but the same rigor, if you like. For example, trials in your country or other parts of Latin America trial. And we can all communicate so much more easily without travel. There's no reason why we shouldn't do that. And we can't, no one country or community can do all these trials themselves. But if we want to replicate data and understand the way different drugs affect different populations, then I think, as well as doing the molecular and genetic work, I think there's huge potential for a really joined up thinking about clinical trials. And independently of pharma, but with pharma as well.
Great, excellent. Okay, Professor Leigh, that was really good, really helpful. There was a lot of information, and really exciting. Thank you so much for this contribution, for taking time of your busy schedule to share this moment with us. We've been in touch as always, and we are looking forward to hearing more news very soon, hopefully.
Yes,
About
it will be soon. I promise you. Just so you know, we're just going through the proofs at the moment, and it's it's been a long, complicated process, and it's taken longer than we would have liked, but mainly because it's a very complex study. And what we were absolutely determined was that the final product, which is not just the paper, it's the whole dossier of hundreds of pages of data, which would eventually go to the regulatory bodies. If they see it that we make mistakes, they could throw the whole thing out. So yes, it's taken us time, but I hope we've done a good job on it, because we don't want to see it fall because of our carelessness.
Great. We are crossing our fingers. So hopefully in next month we may have some news. Hopefully
I
good
think you
news.
will. Definitely, it'll be next month. I can't give you an exact date, but it will
Mhm.
definitely be out in the next month or so. Yeah,
Okay.
clearly. And it will be
Good.
open access so people can look at it if they wish to. They probably find a lot of it rather boring, but at least they can take away the main message.
Well, that's why we have you and all the experts to digest all that information
Yeah.
for all patients and families like ourselves. So yes, we will be alert for that, for those news. So once again, thank you so much, Professor Leigh, for this presentation. And again, we're looking forward to meeting you soon, probably by the end of this year. I don't know, in whatever part of the world. Okay.
Uh, that would be great. Yeah, fantastic. Thank you, and warm regards to everybody out there. And you have our thoughts all the time in trying to help a little bit towards making things better.
Thank you so much, Professor Leigh. Take
Okay,
care.
take care.
Thank you.
Bye then.